Dr. Ronnie George from Changanetrale, Chennai, who is one of the best glaucoma specialists in India with a huge number of publications and peer-reviewed journals. To his credit, will be speaking on medical management of glaucoma, all you need to know for 2021-22. Over to you, Dr. Ronnie.
Hello, and I thank KSS and Srini for the kind invitation to this instruction course. I'm going to speak to you about medical management of glaucoma, all you needed to know for 21-22. So keep in mind that the goals of glaucoma treatment is to maintain the patient's visual function and related quality of life at a sustainable cost. These are the easiest guidelines for 2008, but the guidelines in 2020 are also very similar in terms of the aims of treatment. And the key goal is to preserve vision. And we achieve this by adequate intraocular pressure reduction. And preserving vision also means that we try to reduce progression. So keep in mind that quality of life is very important, and quality of life is done by minimizing the side effects of drugs and also by reducing the risk of progression. So whenever you look at anybody with disease, you need to stage the disease, you need to assess the risk factors, and then decide on target intraocular pressure. So you stage disease based on whether it's ocular hypertension, whether disease is mild, moderate, or severe. So to classify, you need to classify them into mild, moderate, or severe at each visit and at the initial visit. In terms of which drug you would choose, keep in mind efficacy, safety, tolerability, and obviously cost in our situation. And keep in mind also patient factors, because compliance and cost are very, very important from a patient perspective. When it comes to efficacy, don't look at only how much it reduces intraocular pressure. Also keep in mind what is the mean IOP decrease in the treated population. How consistent is the IOP reduction? Do you actually get good 24-hour IOP control? And how long does the effect last? When you look at drug efficacy, in general, the weaker drugs are betoxolol, vinoprostone, topical carbonic anhydrase inhibitors, rho kinase inhibitors, and alpha agonists. The medium are the non-selective beta blockers and the cholinergic agonists, and the strongest efficacy is with the prostaglandins. If you look at the meta-analysis of all drugs, it actually shows you that these are the trough and peak values for all different classes of medications. And it basically shows you the same thing, that the prostaglandins have the highest efficacy. Coming to safety and tolerability, you do see slightly different pictures. When it comes to ocular safety and tolerability, some of the prostaglandins and topical beta blockers have very, very low issues. The highest issues that we see with pilocarpine, obviously, you do get medium side effects with the alpha-2 agonists, the topical carbonic anhydrase inhibitors, the ROCK inhibitors, and bimetoprost and travoprost among the prostaglandins. Systemic safety is another issue. Most of our drugs are fairly safe, except the non-selective beta blockers, which are dangerous, and brimonidine in selected individuals. So keep in mind that even in healthy adults, a topical timolol could significantly reduce heart rate in people who had no other medical issues. And these problems are much more common in children than in adults, because the per body weight distribution of a topical drug is much higher in children. Keep in mind also that these patients are on many systemic drugs, and you need to understand that some systemic drug interactions may be troublesome. The only one contraindication that I'm going to speak about other than this is for adrenergic agonists. In infants and young children, they can cause apnea and they should not be used. Keep in mind that this can also happen in children being breastfed when the mother is using a topical alpha agonist. Concurrent use of MAO inhibitors is also an absolute contraindication when you're using a topical alpha agonist. So what are the general treatment recommendations for patients with glaucoma? You start low and slow. This means we start with the lowest concentration at the lowest suggested frequency of dosing. In order to maximize compliance, it's important that we discuss with our patients what they need to do. We need to simplify the treatment regimen to avoid disruption of the patient's lifestyle and explain to them why it's important that they use medications. So here we have one example of an ocular hypertension. With ocular hypertension, typically our target intraocular pressure is to reduce IOP by about 20. So which in this person with an IOP of 28 is around a target of 21 to 23. So One of the tendencies at this point is to think, okay, I can use any drug like an alpha agonist or a topical carbonic anhydrase inhibitor, which will give me 20% reduction. But that is a wrong approach, because almost any stage of the disease, you should start with the first line drug, which is either a non-selective beta blocker or a prostaglandin analog. So the same applies to an early to moderate glaucoma. Here too, your target intraocular pressure is about 30% less than baseline, and you would be looking at a non-selective beta blocker or a prostaglandin analog. When you have somebody with severe glaucoma, you could again start with a single drug, see whether you achieve a target intraocular pressure reduction of about 40%. Or if that's not possible, consider using a combination therapy. If you have somebody with POAG and cystoid macular edema, obviously prostaglandin analogs are not an option. You will need to use a beta blocker. Let's say this is somebody with CME with bronchial asthma. You may not be able to use either of the first line drugs, and you may need to use an alpha agonist, a topical carbonic anhydrase inhibitor, or a ROCK inhibitor. But this is the only situation where you will use second line drugs as first line. When you decide on efficacy, start on one drug, wait for the drug to reach peak, then you should know the peak effects for each of these medications. Typically, it's between 3 days for pilocarpine to a week for a topical carbonic anhydrase inhibitor, and 2 to 4 weeks for all the other drugs. Reassess that there is at least a 15% intraocular pressure drop once you have started the medication. If there is not a 15% intraocular pressure drop, change. If there is a 15% intraocular pressure drop, then you consider whether this is adequate, whether your target IOP has been reached. If it has been reached, continue and you periodically monitor the endpoints. If it has not been reached, you add a second drug, and then if you reach target IOP, you continue the same way. If your target IOP is not being reached, you substitute the second drug or consider other options. If the drug is not effective on intraocular pressure, you again change monotherapy till it's effective. If it's not effective, you go back to the other options. If you have multiple times tried this and nothing is happening, keep in mind that non-compliance can be a significant factor in these patients. What about combination medications? When you use combination medications, keep in mind whether the combination is additive in nature. So for example, you have drugs which decrease aqueous production or increase outflow. And makes good sense to use a drug which uses a combination of both. So if you have a drug which acts by combination which acts by two different pathways, you would get much better IOP reductions. So how many drugs do we need to use? And what is maximum tolerated medical therapy? So what is MMT? Is the minimum tolerated number and concentration of drugs which produce the maximum drop in IOP, and this is what we should aim for. We should not aim for maximum tolerated medical therapy, which used to be a maximum of 3 drugs, of which at least 2 are in combination. So you're basically using 2 bottles. So now you can actually manage this with 5 drugs. You can use a carbonic anhydrase alpha agonist combination and timolol and a prostaglandin combination. But keep in mind that as you keep on adding drugs, each additional drug gives you much less intraocular pressure reduction. For example, the use of a 4th drug only gives an additional drop of 15 to 20% from that baseline value in 40 to 60% of patients at a single time point, but has poor long-term effects, and you should be planning something more definitive for these patients. This is a patient who I saw recently, and this is the sort of medication that this is on. This is not maximum tolerated medical therapy. This is unsustainable for practically anybody and should not be given. So keep in mind the key goal includes minimizing side effects, and you should look for side effects at each visit and avoid overloading a patient with too many drugs. There are certain other general principles that you should keep in mind. One is teach nasolacrimal drug occlusion to reduce adverse effects systemically. Don't add 2 drugs of the same class. It is not recommended. It doesn't work. Don't use more than the recommended dose, because many of these drugs have tachyphylaxis and actually work less effectively, and you have more side effects when you use them at higher than the recommended dose or the higher than recommended number of times in the day. Start with monotherapy. I like to start with the uniocular therapeutic trial, but that is not mandatory. Wait for the drug to act. Substitute with a more effective drug in case of an inadequate effect, and use combination drugs when more than one drug is needed. Thank you.
Thank you, Dr. Ronnie, for that wonderful presentation.